Welcome to the funnel effect. Today, we are undertaking a really monumental deep dive. We're focusing on the absolutely essential role of specialized imaging in managing one of the most complex heart conditions out there, hypertrophic cardiomyopathy, or HCM. Our source material is truly state-of-the-art. It's the 2025 Clinical Consensus Statement from the European Association of Cardiovascular Imaging, that's the EACVI, part of the ESC. And this entire document, it's dedicated solely to the role of multimodality cardiac imaging in managing patients with HCM. Now, given the seriousness of the topic and just how comprehensive these recommendations are, I really want to take a moment to acknowledge the incredible list of experts who contributed to this foundational work. The primary authors and contributors included names like Nuno Cardim, Christina Hawiga, Saidi Mohidin, Rocio Hinoshar, Alexander Hirsch, Liliana Sabo, Tomas Podlesnikar, Erica Daller-Magellani, Matteo Camelli, Julia Elena Mandoli, Sylvia Rosa, Oliver Leres, Dimitra Antonakaki, Bogdane Popescu, Bernard Cosins, Erwan Donald, Gianluca Pontone, Thor Edvardson, and Stephanie Peterson. And on top of that, the EACVI Scientific Documents Committee reviewers, Philippe Bertrand, Johan Bobat, Rodolfo Citro, Philippe Debonair, Mark Dweck, Neil Keenan, Anna Julia Pabon, and Valtteri Uusitalo. That's quite a collective brain trust, wouldn't you say? They've really synthesized the world's knowledge on this.
It absolutely is. And as you highlighted, this consensus statement is so critical because it moves beyond just, listing available tests. The previous 2023 ESC guidelines definitely elevated imaging's importance, but since then, new evidence has just exploded, particularly around early diagnosis, risk stratification, and these emerging treatments. So our mission today is really to synthesize this consensus and show you how these modern techniques, specifically echocardiography, cardiac magnetic resonance, or CMR, CT, and nuclear imaging, how they must be used together in a coordinated, integrated, and comprehensive way. This is really the era of true multimodality imaging, MMI, in managing HCM.
Okay, let's unpack this then. HCM is, it's notorious for being highly variable, very complex. So before we dive into the specific tools, this consensus statement laid out 4 core clinical needs, where imaging provides that essential high-level information. What are those 4 key roles?
Right. The graphical abstract in the consensus does a great job of defining these 4 sort of increasing levels of value MMI brings. The first role is fundamentally diagnosis. Okay. This means detecting the specific morphological and functional features that actually define the disease. Historically, diagnosis was almost entirely fixated on left ventricular maximum wall thickness, the MWT, being 15 millimeters or more, and unexplained by other things like hypertension or intense athletic training. What's really crucial today, and what the consensus strongly emphasizes, is that the limitations of these old diagnostic definitions, the ones based only on MWT, those limitations are now fully recognized. We need more than just a ruler measurement.
Got it. So MWT is the starting point, but it's clearly not the whole story. What's the second role then, especially when it comes to patient symptoms?
The second role is about addressing symptoms. Imaging is just indispensable for figuring out the underlying mechanisms driving what the patient is actually feeling. Things like shortness of breath, fatigue, chest pain. We use MMI to quantify things like diastolic dysfunction, to characterize mitral regurgitation or MR, and to precisely measure any LV outflow tract obstruction, LVODO. But importantly, the consensus really draws specific attention to a factor that's often underestimated in causing symptoms: abnormal myocardial perfusion. Patients are having symptoms because the tiny blood vessels, the microvasculature, are dysfunctional. And imaging is the only way to really confirm that.
That directly links the structural changes we can see to the patient's actual day-to-day experience. Makes sense. Okay, moving on. What about predicting the future? The prognosis.
That brings us neatly to the third role. Prognosis. This is all about detecting and characterizing those often subtle features that are linked to increased risks. We're talking about the really serious risks: sudden cardiac death, SCD, atrial fibrillation, AF, thromboembolic events like clots, and that dreaded progression towards heart failure. Imaging biomarkers, particularly the ones that quantify myocardial fibrosis or scarring, are now absolutely critical. They often act as the deciding factor in really life-changing decisions, like whether or not to implant a defibrillator. And finally, the fourth role, which is maybe the most challenging: screening. This involves the really delicate task of telling the difference between a very mild, maybe non-hypertrophic myocardial disorder, perhaps someone who carries a known HCM gene but hasn't developed the full thickening yet, and a completely normal, healthy heart. Making that distinction is vital, especially when you're advising on things like activity levels or screening family members.
Okay, that structure really frames the discussion perfectly. Let's start at the beginning then, the disease spectrum itself. HCM is often described as having this highly variable course. Many patients live normal lives, but those risks you mentioned, SCD, LVOTO, AF, and progressive heart failure, often with preserved ejection fraction, HFpF, there's serious concerns.
They absolutely are. The natural history is incredibly variable, particularly in monogenic HCM, which, as I mentioned, accounts for about half of all cases. We don't see a simple, straight-line progression. Instead, the consensus describes the progression through distinct, though sometimes overlapping stages. You can see this in Figure 1 of the document. It often starts with the pure variant carriers. These are people who are genotype positive, G+, meaning they have the faulty gene, but phenotype negative, P, meaning they don't show outward signs of heart disease yet. From there, they might progress into a non-hypertrophic early phenotype stage. Here, subtle functional or structural changes might be detectable, but only with advanced MMI techniques. Then comes the classical phenotype, which is the traditional presentation with that measurable wall thickening. And finally, a minority, maybe around 5 to 10%, progresses to advanced remodeling and overt dysfunction. This is sometimes called end-stage or burnout HCM.
The source material mentions that the annual incidence of a major adverse cardiovascular event like death or an urgent hospitalization is relatively low, somewhere around 5.3%. That sounds low, but it can be misleading, can't it?
Oh, it's definitely misleading if you look at it in isolation. Yes, the overall annual risk might seem manageable, but the long-term risk of something bad happening is significantly greater for patients diagnosed younger, especially those known to carry one of those specific disease-causing sarcomere variants. And, the nature of the risk changes over time, too. While the risk of sudden cardiac death tends to decrease slightly as patients get older, the risks from progressive heart failure and atrial fibrillation, they actually increase significantly, peaking in mid to late adulthood. This really underscores why continuous, sophisticated imaging surveillance is absolutely mandatory throughout the patient's entire life. It's not a one-and-done diagnosis.
Right. Let's hone in on that really challenging group. The G plus P individuals, the gene carriers without the phenotype, and those in the very early non-hypertrophic stages. Table 1 talks about this. If they don't have that hallmark wall thickening, how can imaging possibly detect these disease precursors?
This is exactly where MMI is pushing the boundaries of detection. We're looking for subtle signs, deviations from a normal, healthy heart, even if they don't meet those classic MWT criteria. For example, we might see mild left atrial dilatation, which could suggest slightly elevated filling pressures over time. We also look at abnormal longitudinal function, how the heart muscle shortens lengthwise measured by strain imaging. Or maybe an unusual septal curvature, even before the septum itself gets thick. And CMR is particularly useful here. We can hunt for tiny focal signs of fibrosis using late gadolinium enhancement, or LGE, or look for subtle abnormalities in the myocardial matrix itself using T1 mapping techniques. Furthermore, some advanced functional imaging, like molecular imaging, can even detect impaired energy metabolism in these very early stages.
But the document includes a pretty significant warning about these early findings. It sounds like they're maybe more interesting from a research perspective than as reliable diagnostic tools right now.
That is the critical caveat, absolutely.
Yeah.
And clinicians really need to understand this limitation. While these mild abnormalities do exist, they've mostly been described in small, specialized studies. Critically, none of these findings, not mild LA enlargement, not a tiny bit of LGE, not slightly abnormal strain, none are specific only to HCM. They could be caused by other things. They aren't consistently detected across all patients who eventually do progress, and maybe most importantly, they aren't reliably linked to the future development of classic wall thickening. So if you look at the predictive values, the positive predictive value is low, meaning many G plus P individuals who show these subtle signs never actually develop that criterion level MWT. And the negative predictive value is also low, meaning the absence of these signs doesn't guarantee that the patient won't progress later on. So for now, they primarily guide research rather than driving definitive clinical action for these G plus P patients.
That definitely requires immense diagnostic caution.
Yeah.
Okay, let's pivot now to the other end of the spectrum. The advanced phenotypes, shown in Figure 2. This is that burnout stage, characterized by overt dysfunction.
Yes, this is a devastating and extremely high-risk subgroup for all those major adverse events: SCD, progressive heart failure, AF. The underlying pathophysiology is thought to be this sort of cumulative myocardial injury over time. The consensus suggests this results from repeated bursts of microvascular ischemia, lack of blood flow in the small vessels, which can be symptomatic or even asymptomatic. This recurrent injury ultimately leads to widespread abnormal function. We see this characterized by severe changes in global longitudinal strain, GLS, and eventually the culmination of extensive replacement fibrosis, which is what we visualize as that widespread LGE on CMR. Now, while it's Often described using two extreme examples, the reality is the features typically coexist. The first extreme is the severe systolic dysfunction type. This is characterized by a relatively dilated LV chamber, and the walls are often thin, mainly because muscle has been replaced by fibrosis. The second and actually more frequent type is the restrictive type. This presents with a small, incredibly stiff LV cavity. This results in advanced diastolic dysfunction and severely elevated filling pressures. A key imaging distinction here is that this restrictive form, because of its specific pathology, might actually show little or no LGE, despite being very high risk. This makes techniques like T1 and ECV mapping essential for full tissue characterization in these cases.
That transition from subtle early changes to overt dysfunction really highlights the complexity. The consensus emphasizes that HCM expression isn't monolithic, it's highly variable, influenced by what they call phenotypic modifiers. Table 2 covers this. We're talking about things like environmental factors or baseline patient characteristics that interact with the genetic tendency. This seems to be pushing us towards more personalized thresholds for diagnosis.
Precisely. Exactly. Let's start with one of the most clinically relevant modifiers, sex differences. It's interesting because while males often show more pronounced LV wall thickening and tend to dominate HCM cohorts overall, females actually present a different and often more serious clinical profile. The data suggests females are more likely to have a causative sarcomere variant identified, and when they do present clinically, they are more often found to have obstructive phenotypes and significantly worse diastolic dysfunction. But here's the crucial finding for us as imaging specialists. Women typically have smaller hearts, even when you correct for their body size.
Okay, so if a woman generally has a smaller heart, what's the consequence of rigidly sticking to that standard 15 millimeter MWT diagnostic criterion?
Well, that 15 millimeter threshold actually translates into a greater degree of relative hypertrophy for a woman than it does for a man with a larger heart to begin with. This means that women, on average, are potentially being underdiagnosed or perhaps detected later in their disease course. The clinical consequence of this potential delay, or maybe just a lower threshold of suspicion, is quite stark. Women often present with a higher prevalence of significant heart failure and atrial fibrillation already established at the time of diagnosis. This provides probably the strongest argument for why we urgently need personalized MWT thresholds, indexed to variables like sex and body size, to ensure diagnosis is both equitable and accurate.
That's a really fascinating insight into potential diagnostic bias based purely on physiology. Let's look at some lifestyle and comorbidity modifiers now. Obesity and hypertension. How does MMI help us dissect their contribution to the hypertrophy we see?
These conditions are definitely additive and, frankly, destructive in the context of HCM. Obesity clearly exacerbates the HCM phenotype. It increases both mechanical and metabolic stress on the heart. MMI typically reveals increased LV wall thickness, increased mass, and enlargement of both the LV and the LA. It also significantly impairs diastolic function and increases the likelihood of developing that dynamic LVOT obstruction. The mechanism is a complex mix, partly the increased cardiac workload from the weight itself, and partly the associated metabolic dysfunction. Clinically, MMI is also used to monitor the impact of weight management. The statement highlights that repeating cardiac imaging after significant weight loss is important. It can help clarify how much of the measured hypertrophy was simply a consequence of the weight-related load versus the underlying genetic disease itself.
And what about hypertension? That's the classic phenocopy challenge, isn't it? A condition that can look almost exactly like HCM.
It is definitely the most common mimic, yes. And while some subtle signs might lean more towards HCM, things like myocardial crypts, which are little fissures in the muscle, or very asymmetric patterns of hypertrophy, many of the key CMR markers of pathology are actually shared between the two conditions. Things like non-ischemic LGE, increased Q1 values, increased extracellular volume fraction, ECV. All signs of myocardial injury and fibrosis can be found in both hypertensive heart disease and HCM. Furthermore, hypertension itself can drive a greater magnitude of MWT, often in a mid-ventricular or apical distribution, and it can certainly contribute to provocable LVOT. So, to resolve this diagnostic puzzle, the consensus recommends that MMI, particularly CMR and echo, should be repeated after sustained rigorous control of blood pressure, ideally for 3 months or more. If the hypertrophy regresses significantly with BP control, you lean towards hypertensive heart disease. If it persists despite good BP control, you have a much stronger case for underlying genetic HCM.
Right, makes sense. Now, let's talk about what's arguably the highest stakes differential diagnosis in sports cardiology, distinguishing HCM from the physiological heart remodeling we see in athletes' heart. Table 3 addresses this. This is especially tricky in that MWT gray zone of 13 to 15 millimeters, particularly among black athletes where physiological thickening is known to be more common.
Absolutely. The clinical consequences here are profound. Diagnosing HCM often means exercise prescription, potentially an ICD implantation. Diagnosing athletes' heart allows safe competitive participation, so getting it right is critical. MMI provides multiple high-resolution ways to differentiate that go well beyond just measuring wall thickness. In a true athlete's heart, MMI shows hallmarks of balanced remodeling. You see balanced chamber dilation, normal or even supernormal systolic and diastolic function, and a normal LVEF. Crucially, CMR typically reveals no LGE. If LGE happens to be present, it's usually confined just to the RV insertion points, and it's associated with normal or even low T1 ECV values. And the LV wall thickness to volume ratio is lower, indicating adaptation to volume load, not pathological thickness.
Okay, contrast that with definite HCM. Where do the MMI red flags pop up?
HEM is characterized by atypical LVH patterns, asymmetric, maybe bizarre distributions, often a small LV cavity, maybe less than 45 millimeters. You might see dynamic outflow obstruction, mitral regurgitation that's more than just mild. And critically, you often find evidence of functional impairment that happens before the LVEF drops, like abnormal diastolic function, or reduced global longitudinal strain, GLS. The LV wall thickness to volume ratio is increased, and you frequently find LGE and increased T1 values, suggesting replacement in diffuse fibrosis. The integrated MMI approach is actually so effective here that it's changing guidelines. The consensus references emerging evidence, often supported by this detailed MMI data, suggesting that selected patients with mild, low-risk HDM profiles might now safely engage in intense exercise. Of course, this requires rigorous follow-up and a very careful, shared, informed decision-making process between the patient and physician. This really reflects the confidence we've gained from high-fidelity imaging and separating lower risk from higher risk morphology.
Moving to some other specific contexts, let's consider pregnancy. This involves huge physiological changes, volume expansion, increased cardiac output. How does the HCM heart typically cope with that?
Pregnancy is definitely a period of transient but significant hemodynamic change. Interestingly, the physiological volume expansion and the increased cardiac output can sometimes actually be beneficial for obstruction. It can transiently mitigate or reduce the severity of LVOTO, especially in the first 2 trimesters, because the expanded LV volume helps reduce that outflow tract narrowing. However, the overall increased workload, and particularly the acute stress of labor and delivery, still significantly raises the risks of arrhythmias and acute heart failure. This is especially true for women with severe pre-existing LVOTO or underlying systolic dysfunction. The statement underscores that while most women with HCM tolerate pregnancy well, very close MMI observation and detailed planning for labor and delivery are absolutely mandatory.
And finally, a very contemporary modifier, COVID-19. What did MMI teach us about the vulnerability of this specific patient population during the pandemic?
Right, HCM patients were quickly classified as high risk for severe COVID-19. This was potentially due to elevated expression of the ACE2 receptor, the virus's entry point in the hypertrophied heart muscle. MMI data confirmed that several pre-existing measurable factors significantly increased mortality risk of these individuals if they got COVID. These included advanced age, poor functional class like NYHA class 3 or 4, baseline systolic dysfunction, and critically, the presence of LVOTO. MMI really provided the tools to identify which HCM patients needed the most aggressive protection strategies during the pandemic waves.
Okay, let's now shift gears and look at the core MMI toolkit itself, starting with the measurement of maximum wall thickness, MWT. It still seems to be the quantitative cornerstone of diagnosis that 55 millimeters in adults or 13 to 3 millimeters for family members or gene carriers.
That's right. MWT is still the initial gateway to diagnosis, and it's a mandatory input into that SCD risk calculation we discussed. But it's really important to remember that HCM hypertrophy is often regional, highly asymmetric. This means you can have a patient with severe, localized hypertrophy in just one segment, but their overall global LV mass assessment might still fall within the normal range. Imaging have to find that one segment that crosses the diagnostic threshold.
So echocardiography, box 3 in the document, is the primary modality. Given this asymmetry and regional nature, what are the absolute technical must-dos for getting an accurate measurement? And maybe more importantly, what are the most common mistakes people make, as listed in Table 4?
Accuracy is absolutely paramount here. MWT has to be measured in 2D at end diastole, making sure the entire wall segment is as perpendicular or orthogonal to the ultrasound beam as possible. Probably the #1 technical requirement, especially in patients where the standard echo windows are poor, or if you suspect very localized disease like at the apex, is the routine use of LV opacification contrast agents. These microbubbles are essential to clearly delineate the endocardial border, preventing underestimation, particularly in tricky segments like the apex or the anterolateral wall. As for the measurement errors listed in Table 4, these are common causes of false positives. The two most frequent pitfalls are probably foreshortening, basically, cutting the ventricle obliquely, which artificially makes the walls look thicker, and the inclusion of non-myocardial structures. This means accidentally measuring the thickness of things like the right ventricular moderator band, or parts of the tricuspid valve apparatus, or even left ventricular chordae tendineae or false tendons, and including them as part of the septal thickness.
Failing to differentiate these structures properly leads to overestimation and potential misdiagnosis.
And this is exactly where the complementary power of CMR, cardiac magnetic resonance, steps. Box 4 covers this particularly when echo is maybe inconclusive or the images aren't optimal.
Oh, CMR is indispensable here, as shown in Figure 3. Its superior spatial resolution and its ability to image the entire heart in any plane allow us to accurately assess those segments that echo often struggles with, like the anterolateral wall and the true apex. CMR is also considered the gold standard, the most accurate tool for assessing global LV mass and volume. This is vital for calculating those thickness to volume ratios we talked about in the athlete's heart differential diagnosis. Furthermore, CMR lets us classify the geometric shape of the hypertrophied septum. Is it sigmoidal, neutral, or reversed curve? That reversed curve septum, for example, has been found to be most strongly associated with patients who carry a confirmed positive genetic test for HCM. And finally, CMR provides much better visualization of the right ventricle, helping us identify any accompanying RV hypertrophy, which carries its own distinct implications for both diagnosis and prognosis.
Okay, moving from just the geometry to actually characterizing the tissue itself, let's discuss fibrosis. Late gadolinium enhancement, LGE, on CMR has really revolutionized HCM risk stratification. It's basically the surrogate marker for macroscopic scar tissue, right?
Exactly. LGE is progressive, meaning it tends to increase over time, and is present in about 2/3 of HCM patients overall. It reflects replacement fibrosis. That's the irreversible stage where heart muscle cells, the myocytes, have died and been replaced by collagen scar. And the distribution pattern of this LGE tells us a great deal about the underlying pathology. Figure 4 illustrates this well. We generally identify two major patterns. First, there's intramural, midwall, or epicardial outer wall LGE. This typically represents that replacement fibrosis, and it's often seen in the most hypertrophied segments or at the points where the RV and LV septa meet the RV insertion points. Second, we sometimes see subendocardial LGE that's just beneath the inner lining of the ventricle that does not follow a typical coronary artery distribution. This specific pattern is strongly hypothesized to be related to recurrent myocardial ischemia caused by severe microvascular dysfunction. And there's also a specific red flag pattern noted.
If you see subepicardial or even transmural full thickness LGE that's localized just in the inferior or lateral segments, that should immediately make you think about a Fabry disease phenocopy.
Finding LGE is clearly prognostic, as Table 6 shows. What does the consensus say about its weight as a specific risk factor, especially for SCD?
The presence of LGE is unequivocally linked to poor outcomes. It's associated with roughly a 2.3-fold increased risk of SCD or SCD equivalents, like survived cardiac arrest or appropriate ICD shocks. But the quantification matters most. Extensive LGE, defined as being present in 15% of the total LV mass, acts as a crucial risk modifier. The current ESC guidelines utilize this 15% threshold specifically for patients who calculate into the low or intermediate risk categories based on the standard SCD risk score. If those patients also have extensive LGE, that finding can absolutely tip the balance in favor of recommending a primary prevention implantable cardioverter defibrillator, ICD.
But LGE only captures the large macroscopic scars, doesn't it? This must ignore the more diffuse interstitial fibrosis that's kind of characteristic of the entire disease process. How does MMI get around this limitation and assess that hidden pathology?
That is the critical limitation, and one we're actively working to overcome. LGE dramatically underestimates the total burden of fibrosis because it completely misses the diffuse interstitial expansion, the sort of scaffolding between the cells that hasn't yet progressed to become a replacement scar. This is precisely why advanced mapping techniques are becoming so essential. T1 mapping and the derived extracellular volume fraction, EACVI. T1 mapping measures the intrinsic relaxation properties of the heart muscle tissue itself. These properties are prolonged when there's edema or fibrosis. ECV goes a step further by estimating the actual fraction of the myocardium that is outside the cells, basically, the interstitial space where collagen accumulates. ECV is generally considered superior to native T1 mapping alone because it correlates directly with quantitative measurements of collagen volume taken from myocardial biopsies. It provides a highly sensitive, comprehensive estimate of that diffuse interstitial expansion and is increasingly recognized as a prognostic marker in its own right, even in patients who don't have any visible LGE yet. Figure 4 shows this relationship.
Right, very interesting. Let's move on to function now. You noted earlier that the standard LVEF, or ejection fraction, is often an unreliable marker of systolic function in HCM. If LVEF is insufficient, what advanced tools are needed to really capture that subtle systolic impairment?
Yeah, LVEF is often preserved, sometimes even hyperdynamic or supernormal, in early HCM. This is partly because the hypertrophied muscle contracts very strongly, and partly because the cavity is often small. This combination gives a falsely reassuring ejection fraction number. We need tools that are much more sensitive to the subtle loss of longitudinal function, the shortening along the long axis of the ventricle. This is typically the earliest sign of systolic failure in HCM. The core tool here is global longitudinal strain, GLS. This measures the percentage change in length of the myocardial segments from end diastole, when the heart is full, to end systole, when it's fully contracted. Abnormal GLS, whether it's measured using speckle tracking echo or feature tracking CMR, is often found very early in the disease, sometimes even before the MWT crosses that classic 15 millimeter threshold. It's a powerful tool for diagnosis, for tracking disease severity over time, and for predicting which patients might eventually evolve towards overt systolic dysfunction.
But I recall the consensus statement mentioning that GLS's role as an independent predictor of sudden cardiac death risk is still somewhat debated. Why is that?
Mainly because strain, as a measurement, is highly load dependent. It can be significantly affected by things like blood pressure, the size of the heart cavity, and the overall loading conditions, preload and afterload. This recognized limitation actually led to the development of the next generation of functional metrics, myocardial work. Myocardial work cleverly combines the strain data with an estimate of the afterload usually derived from blood pressure, making the resulting metric less dependent on those fluctuating loading conditions. It categorizes the heart's mechanical work into constructive work, useful pumping, non-constructive work, and wasted work. Studies are showing that in non-obstructive HCM, patients typically have significantly reduced constructive work and increased wasted work. And these work indices seem to correlate better with disease severity and prognosis than strain alone does. Figure 5 illustrates this. The major complexity, though, comes in trying to calculate afterload accurately in the obstructive forms of HCM. That massive intraventricular pressure gradient caused by the obstruction adds a significant non-systemic component to the total afterload, which is tricky to account for precisely.
Okay, now let's consider diastolic function. This is arguably the primary functional problem in many HCM patients, leading directly to those classic symptoms of heart failure with preserved ejection fraction, HFpEF.
Absolutely. Diastolic dysfunction, which is either the inability of the ventricle to relax properly or its increased stiffness, induced compliance, is really what causes the inability to fill adequately. This leads to high LV filling pressures and the development of symptoms like shortness of breath. Echo is mandatory for diagnosing diastolic dysfunction. We use the integrated EACVI 4 criteria approach to diagnose high filling pressures, as shown in Figure 6. We look for specific thresholds. An E ratio, a measure of filling pressure, $10, and a large left atrial volume index to 24 mm/2, an abnormal time difference in the pulmonary vein flow pattern, ARA duration 30 meters, and elevated systolic pulmonary artery pressure, estimated at 35 mmHg. But often the real clinical utility lies in unmasking diastolic dysfunction that isn't apparent when the patient is just resting. This requires performing a diastolic stress test, most typically using exercise echo. This test is essential for clarifying symptoms like unexplained dyspnoea or poor exercise tolerance. The physical exertion increases venous return, more blood coming back to the heart. The small, stiff HCM ventricle simply cannot accommodate this increased volume, revealing a severe lack of diastolic reserve and unmasking the true reason for the patient's symptom limitation during activity.
Moving on to obstruction, which is such a key feature. This is fundamentally a mechanical problem, so it requires high-resolution mechanical imaging. Let's dissect the anatomy, starting with the mitral valve itself, shown in Figure 7. What is it about the mitral valve in HCM that makes it so prone to causing obstruction?
Yes, the mitral valve apparatus itself is often intrinsically abnormal in HCM patients. It's considered a primary manifestation of the disease process. We frequently see things like elongation of the mitral leaflets themselves, or laxity and elongation of the chordae tendineae, the heartstrings. And very commonly we see papillary muscle, PM abnormalities, the muscles that anchor the cords. They might be hypertrophied, abnormally positioned, displaced, or even insert directly into the mitral leaflet instead of the cords. These primary structural defects are what directly contribute to the mechanism of obstruction. The systolic anterior motion, or SAM, of the mitral valve leaflet towards the septum during contraction. The consensus really emphasizes that MMI must precisely describe all these variations. If a patient is being considered for septal reduction therapy, whether that's surgical myectomy or alcohol septal ablation, the surgeon or interventionalist needs to know exactly which papillary muscle might be displaced or whether the leaflets themselves are excessively long. These details dictate the specific surgical approach and any potential valve repair strategies needed alongside the septal reduction.
SAM also typically results in a characteristic posteriorly directed jet of mitral regurgitation, which also needs to be carefully documented and quantified.
Okay, let's look at the resulting obstruction itself. LV outflow tract obstruction, LVOTO, covered in figures 8 and 9. Can you describe the precise sort of two-part mechanism that causes this?
Right, the obstruction results from a synergy combination of mechanical forces. First, there's the purely mechanical narrowing. The severe interventricular septal thickening physically narrows the LV outflow tract, the exit pathway from the left ventricle. Second, there's the functional component. As blood accelerates rapidly through this already narrowed outlet, it creates a low-pressure zone. This is the Venturi effect. This low pressure physically sucks or pulls the anterior mitral valve leaflet towards the septum. This is then compounded by those pre-existing dragging forces caused by the abnormal papillary muscle or chordal insertions we just discussed. The combination effectively slams the mitral leaflet against the septum during systole, causing the obstruction and the visible SAM phenomenon. Diagnosis is highly dependent on using continuous wave Doppler, CWD, echo effectively. When flow is accelerated through a narrow dynamic channel like the LVOT in HEM, CWD displays that very characteristic dagger-shaped and late peaking velocity curve during systole. You can see examples in figures 8 and 9. It must be diagnosed carefully, though. You need to ensure the Doppler sample volume is placed exactly within the outflow tract to avoid accidentally measuring the mitral regurgitation jet, which is going in the opposite direction. If you mismeasure the MR jet, you can severely overestimate the true LVOT gradient.
Now, since this obstruction is often intermittent, or labile as the document calls it, how do we make sure we don't miss clinically significant obstruction that might only appear under stress? Figure 10 talks about provocation.
Yes, we absolutely must systematically provoke it if we suspect it might be labile. The assessment should always start at rest, ideally after the patient has maybe had some food or hydration, as that can sometimes increase gradients. If the resting gradient is low, say less than 30 mmEGs, we then use simple bedside maneuvers like the Valsalva maneuver, straining, or having the patient stand up quickly from a squatting position. But if there's any clinical suspicion of labile obstruction based on the patient's symptoms, like dizziness or near fainting with exertion, then the definitive test is the comprehensive exercise echo. Exercise echo is superior because it applies the most physiological stress. It replicates what the patient experiences in their daily life. It allows us to integrate the measurement of the obstruction gradient. We look for 5 mmHg during or immediately after exercise, with a simultaneous assessment of their symptoms, their blood pressure response, and their overall exercise tolerance. We specifically avoid using drugs like dobutamine for provocation. Dobutamine is non-physiological. It creates an artificial hypercontractile state, and it can actually induce high gradients, even in healthy hearts, leading to false positives. So exercise is preferred.
Then there's the less frequent but seemingly higher risk version. LV mid-cavity obstruction, LVMCO, shown in figure 11. What makes this particular type so dangerous?
LVMCO is structurally different. It involves a focal narrowing, usually caused by massive hypertrophy of the papillary muscles themselves, creating a sort of hourglass shape within the ventricle. This effectively divides the LV cavity into a basal portion and an apical portion. The resulting high-pressure jet generated by this mid-cavity obstruction is directed straight towards the LV apex. This causes significant mechanical trauma over time and frequently leads to the formation of a left ventricular apical aneurysm, a bulging, thinned-out area at the tip of the heart. This aneurysm formation is highly dangerous. It's recognized as a powerful independent marker for progressive heart failure, for life-threatening ventricular tachyarrhythmias, VT, and also carries a very high risk of thrombus or clot formation within the aneurysm itself, which can then embolize.
And you mentioned there's a specific imaging challenge here. The Doppler signal used to measure the gradient can actually be misleading.
Yes, that's right. In severe LVMCO, the Doppler velocity measurement frequently underestimates the true pressure gradient across the obstruction. This is because the obstruction can be so severe and the cavity so narrow at that point that blood flow can actually cease entirely in mid-systole. When the flow stops, the Doppler signal abruptly disappears, creating a very characteristic lobster claw-shaped envelope on the spectral display, figure 11. Seeing this visual pattern indicates severe flow cessation. In such cases, non-invasive imaging has really reached its limit for gradient assessment, sometimes necessitating invasive pressure wire measurements during a cardiac catheterization for accurate quantification. CMR is also vital here for clearly visualizing the apical aneurysm, detecting any potential thrombus within it, and assessing the amount of fibrosis or scar tissue present in the aneurysmal wall.
Okay, so as an integrated strategy, MMI obviously needs to look beyond just the left ventricle. What does imaging the left atrium LA tell us about the severity and the chronicity of the HCM process? Figure 13 touches on this.
The LA acts almost like a pressure gauge for the left ventricle. It reflects the chronic strain imposed by that stiff, non-compliant LV and the resulting high filling pressures over time. So LA remodeling, which includes both dilation and enlargement and critically dysfunction, is a very powerful prognostic marker, figure 13. Simple imaging parameters like the LA antero-posterior diameter, if it's 25 millimeters, are directly incorporated into the ESC-SCD risk calculator. But maybe more importantly, advanced techniques are now focusing on LA function. LA reservoir strain, measured using speckle tracking echo, reflects the LA's ability to stretch and fill. If the LA reservoir strain is reduced, specifically a value less than 23%, this has been shown to be predictive of patients developing new onset atrial fibrillation and is also linked to worse long-term outcomes overall. It demonstrates that LA dysfunction often precedes and predicts future electrical instability.
And what about the right ventricle, RV? Is it just an innocent bystander in HCM?
Absolutely not. The RV is often involved, and we must assess it. We should always measure the RV maximum wall thickness. Normal is generally considered 5 millimeters. Finding RV hypertrophy can mean several things. It can be a feature of the primary HCM disease process itself. It can be a clue pointing towards a specific phenocopy, like Fabry disease or Danon's disease. Or it could be secondary hypertrophy due to pulmonary hypertension caused by chronically elevated left-sided filling pressures backing up into the lungs. Clinically, the presence of significant RV hypertrophy has been independently associated with the presence of ventricular arrhythmias, suggesting that its involvement is likely a marker of overall increased disease severity and electrical instability.
Okay, let's delve deeper now into some of the advanced functional imaging, specifically around ischemia and microvascular dysfunction. Figure 14 is relevant here. We know HCM patients often suffer from ischemia, even if they don't have blockages in their main coronary arteries. What are the underlying mechanical and physiological reasons for this?
Right, the ischemia in HCM is typically driven by a chronic mismatch between oxygen supply and demand within the heart muscle wall itself. Mechanically, the massively thickened walls cause extravascular compression of the tiny intramuscular arteries and arterioles, physically reducing blood flow during contraction. Physiologically, the microvasculature itself is often abnormal. We see reduced capillary density, structural remodeling of the small arteries with thicker walls, and functional impairment. The vessels don't dilate properly when needed. When you couple this impaired supply with the increased oxygen demand from the hypertrophied, often hypercontractile muscle, and also consider the difficulty the heart has in filling during diastole, which is when coronary perfusion mainly occurs, the heart effectively operates in a chronic state of relative oxygen deprivation. It's also noted that patients with confirmed sarcomere variants typically exhibit more severe microvascular dysfunction. So, since significant epicardial coronary artery disease needs to be excluded first, and cardiac CCT is often the ideal tool for that, MMI then provides the specialized functional tools to directly assess the microvasculature itself. Figure 14.
What are those specific functional MMI techniques then? How do we measure this microvascular dysfunction?
Well, first, with stress echo, we can measure the coronary flow velocity reserve, CFVR. This involves measuring blood flow velocity in one of the major coronary arteries, like the LAD, both at rest and after giving a vasodilator drug like adenosine. Impaired CFVR means the artery can't dilate adequately to increase flow when needed. This impairment has been strongly associated with worse functional capacity, like a low peak VO2 on exercise testing, and also poor biventricular systolic performance. Second, CMR perfusion imaging, often performed using quantitative T1 mapping techniques during vasodilator stress, adenosine or rigadenosine. This technique can show reduced absolute stress myocardial blood flow, specifically in the most hypertrophied and fibrotic segments of the LV. This technique is highly sensitive. For instance, the consensus document points out that apical perfusion defects are found almost universally in patients who have apical HCM, regardless of how mild the hypertrophy might appear just by measuring thickness. Third, and arguably the most precise tool currently available, is PET, positron emission tomography.
PET allows for the determination of absolute quantitative myocardial blood flow, QMBF measured in milliming, and the derived myocardial flow reserve, MFR. This offers unparalleled insight into the severity of the microvascular disease. Studies using PET have convincingly demonstrated that severe microvascular dysfunction identified by PET is a powerful long-term predictor. It signals an increased risk of future adverse LV remodeling, the development of systolic dysfunction, and even all-cause death.
Now we arrive at perhaps the most critical application of all this MMI data, predicting the risk of sudden cardiac death and guiding that crucial decision about primary prevention ICD implantation. Figure 15 and Table 6 focus on this.
Yes, the entire clinical management strategy often hinges on this risk assessment. The ESC-HCM risk SCD model is central to calculating this risk for patients who are 16 years or older. This model integrates key clinical data like age, family history of SCD, unexplained syncope, NSVT on Holter, with 3 core MMI parameters. Importantly, these MMI parameters are treated as continuous variables in the model, reflecting that more severe findings equate to higher risk. These are maximum wall thickness, the maximum left atrial anterocrupier dimension, and the peak LVOT gradient, Figure 15, Table 6.
Okay, so the model gives a risk score, but for patients who calculate into the low or intermediate risk categories based on that score, MMI provides these crucial risk modifiers that can really sway the final decision about an ICD. What are those specific imaging findings again?
All right, these are the 3 major MMI-derived risk modifiers that, if present, argue strongly in favor of recommending an ICD, even if the calculated ESC score itself falls into the low or intermediate range. Number 1, extensive LGE defined as 15% of the total LV mass, as quantified by CMR. This represents a significant scar burden that reaches a tipping point for arrhythmia risk. Number 2, the presence of an LV apical aneurysm, particularly if it shows associated fibrosis, LGE, within its wall. As we discussed, this structure is a known anatomical substrate for dangerous ventricular arrhythmias. And number 3, evidence of LV systolic dysfunction, defined conventionally as an LVEF 50%.
Let's pause on the LGE quantification for a second. You mentioned earlier there's some debate about that 15% threshold, and maybe more importantly, exactly how it's measured. Does this lack of standardization across different centers affect how confident clinicians should be when applying this modifier?
That is a fundamental challenge, yes, and it's explicitly recognized as a gap in the current evidence. There is, unfortunately, no universally accepted standardized method for quantifying LGE extent right now. Different centers, and even major clinical trials, use different techniques. Some use a threshold of 4 standard deviations, SD, above the signal intensity of normal nulled myocardium. Others use 5 SD, some even use 6 SD. These different thresholds can significantly change the calculated percentage of scar in the very same patient. Some meta-analyses looking at outcomes have even suggested that perhaps a slightly lower threshold, maybe around 10% LGE, might actually be more predictive of adverse events than the current 15% cutoff. The clinical implication is that while LGE is undeniably a powerful prognostic tool, clinicians absolutely must be aware of the specific quantification method being used in their local lab and consider this inherent variability when interpreting results and applying that 15% threshold. This really emphasizes the urgent need for future research to establish a single, robust, universally accepted quantification standard.
Okay, that's a really important practical point. Let's shift now to using imaging for treatment monitoring. The introduction of these new cardiac myosin inhibitors, CMIs, drugs like mavacamten and aficamten, has really been a game changer for obstructive HCM. What is MMI's absolutely mandatory role when patients are on this therapy? Figures 16 and 17 are relevant.
MMI is inextricably linked to CMI therapy, simply because of the drug's primary mechanism of action, which is to reduce excessive LV contractility. To prevent oversuppression of contractility, the patient's left ventricular ejection fraction, LVEF, absolutely must be closely and regularly monitored. Figures 16 and 17 outline this. Echocardiography is the primary modality specified for this mandated monitoring. A baseline LVEF is required before even starting treatment. Typically needs to be 55%. The most crucial monitoring aspect is the safety margin. A fall in LVEF to below 50% requires immediate, temporary, or permanent discontinuation of the CMI. This means patients need frequent, standardized echo assessments, especially early on, sometimes every few weeks during dose titration. While echo primarily focuses on LVEF and the obstructive gradient, CMR can provide more comprehensive, holistic assessment of the overall LV and LA remodeling that occurs in response to the treatment, which might lag behind the more immediate functional changes seen on echo.
And what about monitoring after the procedural treatments, surgical myectomy or alcohol septal ablation? How is imaging used there?
Imaging guides basically every step of those procedures too. Pre-procedurally, transesophageal echo, TOE, sometimes CMR and often CCT, are necessary to meticulously map the precise anatomy and the mechanism of the LVOT obstruction. This is crucial for surgical planning or identifying the correct septal artery for ablation. During the alcohol septal ablation procedure itself, myocardial contrast echo is used dynamically in real time to select the exact septal perforator vessel that supplies the target area of the septum responsible for the obstruction, ensuring the procedure is precise and effective while minimizing damage to non-target areas. Then, post-procedure, typically 1 to 6 months later, MMI, usually transthoracic echo, TTE, evaluates the success. We look for evidence of septal thinning in the treated area and, most importantly, a significant decrease in the LVOT gradient. CMR can also be used post-procedure to assess the precise size and extent of the induced scar after alcohol ablation and to track changes in MWT over the longer term.
Okay, let's move into the final major section, differentiating HCM from its many, often dangerous mimics or phenocopies. Figure 18 provides an overview. This seems like one of the most critical uses of advanced MMI playing detective, essentially.
It is absolutely essential because misdiagnosis here leads to profoundly incorrect and potentially harmful management strategies. We rely heavily on MMI to spot the specific red flags or unique imaging signatures that point away from classic sarcomere HCM and towards one of these mimics. Let's take cardiac amyloidosis as an example, figure 19. Echo typically shows what looks like global hypertrophy, often with evidence of high LV filling pressures and biatrial dilation. But the key echo red flag is often the apical sparing pattern on global longitudinal strain. This is where strain, or deformation, is relatively preserved right at the very apex, compared to the severely reduced strain in the basal and mid-segments of the ventricle. It's quite characteristic. On CMR, amyloid typically shows a diffuse, often subendocardial pattern of LGE. But the T1 mapping is often the definitive, non-invasive clue. Native T1 values are highly prolonged, reflecting the infiltration of the myocardium by the abnormal amyloid protein. Then, typically, DPD SPECT nuclear scanning is used to confirm the TTR subtype of amyloidosis non-invasively.
What about Anderson-Fabry disease? Figure 20 focuses on this. What's the unique imaging fingerprint that helps distinguish it?
Fabry disease, which is a lysosomal storage disorder, often presents with concentric LV and sometimes RV hypertrophy, usually with preserved EF initially. On echo, a subtle clue might be a selective reduction in longitudinal strain, specifically in the basal infralateral wall. This often corresponds to where patchy LGE appears on CMR. But here's the absolute critical distinction that relies on T1 mapping. Unlike HTM or amyloidosis, where native T1 values are usually increased due to fibrosis or infiltration in Fabry disease, the native T1 is often diffusely decreased. This happens because the underlying enzyme deficiency leads to the accumulation of globotriaosylceramide, a fatty substance, within the myocytes themselves, and this lipid accumulation actually shortens the T1 relaxation time. This finding of low T1 is a unique and powerful non-invasive differentiator for Fabry. And ultimately, let's mention Danos disease. This is a rare X-linked cardiomyopathy characterized by vascular changes in the muscle cells. It often results in strikingly severe concentric hypertrophy that frequently involves the RV free wall as well. The definitive MMI finding on CMR here is often the LGE pattern.
Patients typically have extensive LGE throughout the thickened walls, but it consistently and selectively spares the mid-portion of the interventricular septum. This specific mid-septal sparing pattern is considered a highly characteristic clue pointing towards Danon's disease.
Wow, that forensic breakdown really demonstrates how sophisticated and integrated MMI has become today. Looking forward now, the consensus identifies two major transformative areas shaping the future: technology, especially AI, and the development of new diagnostic criteria. Let's start with artificial intelligence, AI, and machine learning. How are they expected to impact HCM imaging?
AI really promises to solve some of the current bottlenecks we've discussed, particularly around variability and quantification. AI and machine learning algorithms are being developed to enhance the automation, speed, and consistency of measuring things like MWT, LGE volume, and ventricular function parameters. This helps remove human error and inter-observer variability. But perhaps even more excitingly, AI is being applied to radiomics, as shown in Figure 21. Radiomics involves extracting a vast number of quantitative features from medical images, things related to texture, patterns, signal heterogeneity, many of which are completely invisible to the human eye. Machine learning models trained on these radiomic features are already demonstrating incremental prognostic value. They seem to improve the accuracy of SCD risk prediction models beyond what traditional parameters like MWT or LGE percentage alone can provide.
I found that concept mentioned in the paper, virtual native enhancement, particularly intriguing. The idea of replacing the need for gadolinium contrast. How would that work?
Yes, this is a major area of research, especially relevant for younger patients or those needing frequent serial follow-ups, where repeated gadolinium exposure is a concern. Virtual native enhancement uses AI algorithms to analyze subtle morphological and functional radiomic features extracted purely from non-contrast MR sequences, like standard SOC images, native T1 and T2 maps. The AI essentially learns the patterns associated with scar tissue and synthesizes a virtual scar map directly from the native, unenhanced data. The goal is to provide a reliable surrogate for traditional LGE imaging. If this can be robustly validated, it could genuinely allow for gadolinium-free scar screening, completely transforming follow-up protocols. However, the big caveat remains. This technology needs significant technical refinement and, more importantly, extensive clinical validation in large, diverse, multi-center data sets before it could possibly be considered for routine clinical use.
That makes sense. The other major shift predicted is abandoning that decades-old one-size-fits-all 15-millimeter rule in favor of new, personalized diagnostic criteria. Why is the shift happening?
Yes, the rigid 15-millimeter threshold is conceptually becoming obsolete, primarily because it completely fails to account for known biological variability related to sex, body habitus, size, age, and potentially race or ethnicity. Figure 22 highlights this need. The movement is definitively towards personalized indexed criteria. For instance, take apical HCM, a subtype often missed because the apical thickness rarely exceeds 15 millimeter. New research has indexed apical thickness measurements to body surface area, BSA. They propose defining the upper limit of normal apical thickness as somewhere between 5.2 to 5.6 millimeter 2. Utilizing this index measurement significantly improves the diagnostic accuracy for apical HCM compared to the fixed 15 millimeter rule. This approach, indexing thickness measurements to relevant patient variables, will likely be extended to other LV segments and potentially other imaging markers as well. It fundamentally moves the diagnosis away from a simple binary measurement towards a more continuous multi-parametric score that reflects individual patient characteristics. We should also briefly mention the importance of infrastructure here. The continued growth of large-scale imaging registries and biobanks, like the International Share Registry or national projects like the UK Biobank, is absolutely crucial. These massive data sets are the engines that will be needed to validate these new AI scores and personalized diagnostic thresholds, ensuring they're clinically reliable, generalizable, and globally applicable.
This has been a truly comprehensive tour of modern HCM management through the lens of imaging. The underlying theme is crystal clear. MMI isn't just a collection of tests, it's an integrated strategy, constantly evolving and moving us steadily toward high-fidelity, personalized patient care. Before we conclude, based on this extensive consensus statement, what are the most pressing evidence gaps that future research likely leveraging these new technologies absolutely must address? Box 5 lists some key ones.
Yes, the consensus explicitly lists several significant areas where we need more robust evidence. Firstly, despite their promise, we still lack definitive large-scale multi-center validation for several of the advanced echo and CMR techniques, specifically GLS, T1 mapping, and EACVI, to function as truly independent risk factors for sudden cardiac death, separate from the established components of the ESC risk score. Secondly, we urgently need to solve the LGE quantification problem. We must establish a universally accepted, standardized method so that a 15% scar burden measured in London means exactly the same thing as a 15% scar burden measured in Lisbon or Los Angeles. Third, we need studies to prove the actual clinical utility and downstream impact of implementing these conceptually elegant new personalized diagnostic criteria. Do they lead to better patient outcomes? And finally, we need to definitively clarify the precise role that microvascular ischemia, whether quantified by PET or CMR perfusion, in actually driving symptom limitation and dictating the future progression of fibrosis and dysfunction. Is it a bystander or a key driver? So, given this rapid adoption curve we're seeing for AI, for radiomics, for these personalized thresholds, and the clearly recognized inadequacy of single, fixed measurements in such a genetically heterogeneous disease, here's perhaps a provocative thought for you and for our listeners to consider. How soon will that conventional 15-millimeter cutoff for maximum wall thickness be considered clinically obsolete, replaced entirely perhaps by an indexed multi-parametric, potentially AI-derived diagnostic score that seamlessly integrates morphology, function, and tissue characterization into a single personalized risk assessment?
That is indeed the essential question defining the future of HCM diagnosis and management. And if this 2025 consensus statement is any indication, that future seems to be arriving much faster than many of us in day-to-day clinical practice might currently anticipate. The depth of insight that MMI now provides is truly extraordinary. Thank you for watching The Funnel Effect.